You are welcome to my channel. Today I'll be addressing hemophagocytic lymphohistiocytosis, otherwise addressed as HLH. I will define some terms. Hemo simply means blood, while lymphocyte is a type of white blood cell involved in immune process. We have two types of lymphocyte, T and B lymphocytes. Histiocytes are immune cells, and they are found in bone marrow, the skin, the blood, liver, lungs, spleen, and lymph nodes. Later on, you understand why the clinical features will involve lymphadenopathy, splenomegaly, hepatomegaly, and so on. Histiocytosis simply means excessive histiocytes, while phagocytosis is a process by which a cell uses its plasma membrane to engulf or ingest other cells or particles like dead or dying tissues or microorganisms. Now, with that in mind, we can now go straight to HLH. This is an aggressive and life-threatening immune activation. It is known by the symptoms and signs anyways, probably due to genetic problems, and sometimes is as a result of environmental issues. HLH is very rare. Glad to know that, right? But it has the potential to be fatal, meaning, though it is rare, but the few people that will have it might die from it. Here we'll be battling with excessive immune activation. Be suspicious of HLH when there is sudden onset of fever and malaise. When there is generalized lymphadenopathy and you've ruled out HIV, you've ruled out malignancy, be suspicious. Rule this out also. In the face of pancytopenia, sepsis, and systemic inflammatory response syndrome without any obvious cause around, be suspicious that you might be battling with hemophagocytic lymphohistiocytosis. Now, the causation. It might be primary, meaning it is hereditary or inherited. In that case, we'll be dealing with genetic issues, gene defect. It might be X-linked lymphoproliferative disease. Here, there will be immune response to Epstein-Barr virus or any other viral illness. And you know the route through which X-linked is inherited, right? A female with one defective X chromosome will not show the disease, but can pass it on to her son. Familial HLH has 5 types 1 to 5. So familial hemophagocytic lymphohistiocytosis or familial erythrophagocytic lymphohistiocytosis will be another name for the familial form of HLH, types 1 to 5. This one is inherited by autosomal recessive pattern, meaning the chances of the offspring having this disease under this situation will only occur if the defective genes have been inherited from each of the parents. And the probability here will be 25% in each pregnancy. Now, secondary causes of HLH, meaning it is not genetic in origin, so this time is environmental. Is either as a result of infections or rheumatological diseases or autoimmune diseases. Of course, when there is one autoimmune disease, we have to look out for other autoimmune diseases. Here might be a result of malignancy, mostly hematological malignancies, or certain medications, or immunodeficiency conditions, or metabolic diseases. In HLH, there will be immune dysregulation, and this will lead to a lot of events. One is increased activation of cytotoxic T cells. Macrophages will be in place, increased amount of some interleukins, increased cytokines, and so on. There are certain different nomenclatures when it comes to HLH. When the main issue is genetic or environmental factors, then it is given a name called Hemophagocytic Lymphohistiocytosis disease, or HLH-D. Another name will be given when signs and symptoms are associated with immune activation due to lymphocyte cytotoxic genetic defects. Here it will be called HLH syndrome or HLHS. Still on the nomenclature, when HLH disease resembles the known HLH syndrome, but it is not actually due to genetic defects, and it is not environmental in origin, then it has a different name. And that would be Hemophagocytic Lymphohistiocytosis mimics, or HLH mimics, or HLHM. When it is occurring primarily in juvenile idiopathic arthritis or just any rheumatological diseases, it is given another name. And here it will be called reactive hemophagocytic syndrome or macrophage activation syndrome. We are done with the names. Oh, wow, right? Okay, now epidemiologically, get this right. This is more of pediatric issue. I'm not saying it's not going to be found in grown-ups or elderly people, but majorly it is pediatric issue. And infants will mostly affected. The highest incidence will occur in children less than 3 months old. Male to female ratio is equal, that is 1:1. About 1 in 3,000 children in hospitals will likely be diagnosed with HLH. That is hard to hear, right? It, however, could be diagnosed in all ages. Like I've said earlier, adult males will be more than females. Let me explain. The other time I said male to female ratio in pediatric age group is 1:1. When this is diagnosed in elderly people, adults, male to female ratio will not be the same. More males will be affected as adults than females. Still on epidemiology, the probability of malignancy associated with HLH is higher in Japanese and East Asians. A quarter cases are familiar, and that could be familial hemophagocytic lymphohistiocytosis or familial erythrophagocytic lymphohistiocytosis, which will have autosomal recessive pattern. Remember, I said that earlier and I'm giving the explanation, right? You may pause and rewind back to that explanation. So just meaning autosomal recessive is going to give 25% probability in each pregnancy. Pathophysiology. When there's an abnormal immune activation, There will be excessive inflammation, and of course, that will be followed by tissue destruction. The hyperinflammation is due to lack of downregulation by activated macrophages and lymphocytes. The cytokines released will stimulate bone marrow macrophages, and that will lead to engulfment of hematopoietic cells. Going further to deal with the cell types that will play key roles here, the macrophages will present antigens to lymphocytes and secrete excessive cytokines, while the natural killer cells are capable of removing the infected, stressed, or damaged cells. The cytotoxic lymphocytes will break down macrophages, and there will be altered numbers of CD4 to CD8, with increased CD8 and decreased CD4 to CD8 with the probability of the best survivor. Cytokine storm is the excessive cytokine production, and it is likely caused by persistent activation of macrophages, the natural killer cells, and cytotoxic lymphocytes. Examples of cytokines are tumor necrosis factor alpha, interferon gamma, interleukin 6, 10, and 12. Now, the clinical features. Onset of symptoms is usually within the first months of life. Like I said earlier, that the first 3 months of life. And that will be associated with fever, cytopenia, enlarged liver, that is hepatomegaly, enlarged spleen, and neuroanomalies. Still on clinical features, there will be non-specific symptoms like fever and malaise, and sometimes with symptoms of HIV/AIDS, T-cell lymphoma, that is T lymphocytes, histoplasmosis, juvenile rheumatoid arthritis, or autoimmune diseases. We may be dealing with HLA that is known amongst patients with HIV, some with disseminated infections and others without disseminated infections. Let me explain. Hemophagocytic lymphohistiocytosis is known amongst HIV positive patients. Some of them will have disseminated infections. Some will not have disseminated infections. It is also known, HLH is also known as a complication of acute disseminated granulomatous disease called histoplasmosis, and that will also be prominent in patients with HIV, but could be found in those without HIV also. Syntacin binding protein 2 mutation will lead to bleeding, diarrhea, censorineuria, hearing loss, hypogammaglobulinemia, and there will be defective gram-negative bacterial killing. Why that? The defective gram-negative bacterial killing is going to occur because there will be defective granule mobilization by neutrophils. Neuro or central nervous system will not be left out. We might be faced with encephalitis, changes in mental status, seizures, ataxia, demyelinating peripheral neuropathy, posterior reversible encephalopathy syndrome. Now, there may be anemia, fever of unknown origin, splenomegaly, thrombocytopenia, or renal impairment. There could be rashes. Remember, I listed skin as part of where you're going to find histiocytes the other time. Edema, petechiae, purpura, and albinism. Kawasaki disease features can occur here with conjunctivitis, red leaves, and cervical lymphadenopathy. Remember, autoimmune generally, right? And recurrent infections. Malignancy, remember I've said earlier that particularly hematological malignancy and rheumatological symptoms, immunodeficiency syndrome, and viral infections like Epstein-Barr virus, cytomegalovirus, and could even be bacteria like Mycobacterium tuberculosis in TB, fungi, and parasites. There may be hypofibrinogenemia, hypertriglyceridemia, hemophagocytosis, ferritin greater than 500 microgram per liter, and we're going to pick something, soluble CD25. That is going to be measuring interleukin-2 receptor, and CD25 will be elevated. Respiratory distress syndrome, respiratory failure with time, hypotension. Remember, from sepsis to SIRS to hypotension, multiple organ failure, low natural killer cell activity or absent natural killer cell activity. From sepsis to severe inflammatory response syndrome to multiple organ failure and, of course, death. Diagnosis. The best is to be suspicious. Early suspicion is best in diagnosis, and that will give us the better outcome. The diagnosis of HLH is usually delayed because most of the times another diagnosis will be made, HLH will be missed, and the patient will likely die from that. Why that? There are non-specific symptoms at presentation. Failure to diagnose HLH on time has led to the increase in mortality recorded. Before, the following were considered while making the diagnosis. A. Fever, splenomegaly, cytopenia, hypertriglyceridemia or hypofibrogenemia, hemophagocytosis. Later on, B came to being, and that would be low or absent natural killer cell activity, hyperferritinemia, and high soluble interleukin-2 receptor levels indicated by soluble CD25. Remember, I've said that just a while ago. In those days, the diagnosis would be made based on 5/8 from A and B above. Now, how can we make the diagnosis on our own? First thing first, be suspicious that could this be HLH? Let's have a thorough history. Okay, is this running in your family? Is this your first child? How about the first, second, third, and so on? Anyone diagnosed with HLH in your family? Any history of Epstein-Barr virus, viral infections? No, the fever, blah, 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 blah. Then have a physical examination done. You are looking for petechiae, purpura, looking for splenomegaly, hepatomegaly, neuro examination fully done, cardiovascular done, features of sepsis, and so on. Then we'll head to the lab. What are we checking for? We want to see what is happening to the liver, right? Liver enzymes. It will be raised. Bilirubin, it will be on the increase. How about triglycerides? Remember, hypertriglyceridemia. It will be high. We are still in the lab. Now I want to rule out infection. Remember I've said earlier, if it is primary, that is genetic in origin. If it is secondary, it could be due to infection, right? Okay, we want to rule out that infection. We have a blood culture done, we run microscopy culture, and sensitivity. Then position the patient for what? For lumbar puncture. Rule out contraindications to lumbar puncture. None is present. Okay, have it done. Get the CSF analysis, gram staining, and so on. Polymerase chain reaction. Remember, histiocytes will be found in the bone marrow. It's going to affect the bone marrow. So we're going to have bone marrow aspirate. So we are not done at the lab. We want to see what is happening to the D dimer. There could be increased D dimer, and we'll check the clotting profile for DIC, that is disseminated intravascular coagulopathy. So what is happening to PT? That will give us clue to liver-related clotting factors. And APTT, TT, BT, that is bleeding time, von Willebrand factor, and platelets. We do liver biopsy, CSF analysis, like I've alluded to earlier, immunological profile, and of course, genetic testing and HLA testing. When the results are back, we want to see the level of hematocrit, which is expected to be low. What is the picture of the complete blood count? What's happening to the platelet? Because we're expecting thrombocytopenia. You've assayed the ferritin level, right? Remember, I've said earlier, hyperferritinemia. So we're expecting something between 5,000 to 10,000 nanogram per mil. And remember, I've mentioned soluble CD25. So we want to see the serum soluble interleukin-2 receptor. That is an important disease marker in hemophagocytic lymphohistiocytosis. If you have not remembered anything at all as per the diagnosis, please take this home. Serum soluble interleukin-2 receptor that will be represented by soluble CD25 is an important disease marker in HLH. So you can likely conclude your diagnosis without that parameter. And finally, on diagnosis, we can have radiological investigations done starting from the most available and go up, that is ultrasound. Now, we want to see what's happening to the spleen, to the liver, to the kidney, now to the abdomen generally. And you can have your echo that will help to look the more into the heart, right? And you have CT for everything from head to the respiratory system, the lungs, to the heart, to the liver, to the spleen, to the kidneys and the abdomen generally, and of course magnetic resonance imaging that will give us clue, the more, and delineates so many other structures. Now, the differential diagnosis. So, if it is not HLH, what else could it be? It might be thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome, or transfusion-associated graft versus host disease, encephalitis, will also be Kawasaki disease, or just sepsis, or severe inflammatory response syndrome. It might be liver disease, or liver failure, could be child abuse, or drug-induced thrombotic microangiopathy. Might just be infections, like mycobacterial tuberculosis causing TB, or fungal infection, or parasitic infections by parasites. Might be viral infections with Epstein-Barr virus, or cytomegalovirus, or human immunodeficiency virus. The differential diagnosis could include cytophagic histiocytic panniculitis. Might be dressed. I'm not saying you should go and get a clothes and dress up. Might be drug reaction with eosinophilia and systemic symptoms. Might be ARPS, that is autoimmune lymphoproliferative syndrome. The differential diagnosis might be macrophage activation syndrome or reactive hemophagocytic syndrome or multiple organ dysfunction syndrome. Now, the treatment. The lifespan is drastically reduced to just few months. Why that? If there is no early treatment. So, early suspicion, correct diagnosis, ruling out any other possible diagnosis if definitive diagnosis is not made will be pretty helpful, and start treatment on time. Early diagnosis and treatment is the key. Treat at the slightest suspicion. With multiple organ failure, death is imminent. In about 30 years ago, the protocol for HLH was developed, and that has reduced mortality by half in 6 years. In 1994, HLH treatment protocol was instituted. Then dexamethasone with etoposide was helpful. If central nervous system disease is occurring, you are allowed to use intrathecal methotrexate with hydrocortisone. If the central nervous system disease is with gene mutation and relapse, you can use hematopoietic stem cell transplantation. In 2004, a new protocol surfaced. Here, cyclosporine became helpful to be used earlier in the treatment. Hydrocortisone with methotrexate will be adopted for intrathecal administration. You can start treatment if inflammation is ongoing with increased ferritin greater than 10,000 nanogram per ml, or increased D-dimer, increased liver enzymes, with or without genetic screening outcome. You have to treat any identified trigger or triggers, like rheumatological conditions. We have to treat the underlying malignancy if it is related to malignancy. We must consult to hematologists and oncologists, and hematopoietic stem cell transplantation is deemed to be helpful. Monitoring. We can monitor HLH by using biomarkers like liver function tests, complete blood count, D-dimer, ferritin level, fibrinogen, and soluble hemoglobin aptoglobin scavenger receptor, SCD163. We have to check out for the triggers and treat appropriately. For example, if it is infectious in origin, like fungi, we give antifungal. Bacteria, antibiotics, viral, antiviral, and parasite, antiparasitic agents. If it's associated with malignancy, we have to treat appropriately with the help of hematologists and oncologists. If what we are dealing with is as a result of Epstein-Barr virus, we must give intravenous immunoglobulin or disease-modifying antirheumatic drugs. If the culprit is HIV, then grab highly active antiretroviral therapy. If nothing is improving or is actually getting worse, then we have to commence HLA-specific therapy. We have ample of sources to choose from. We can make use of desmotisone, hydrocortisone, prednisone, cyclosporine, or methotrexate. We can also use vincristine with cyclophosphamide, doxorubicin, oncovin, etoposide, blood transfusion if deemed fit, fresh flushing plasma, hematopoietic stem cell transplantation, hemopaluma. Complications. Liver will be in trouble, so there may be liver failure. The renal system will be in jeopardy with probable renal failure. Respiratory system will face disaster with likelihood of respiratory failure. CNS is not left out, no, it's not out of the wood with CNS degeneration. Prognosis. Mortality is pretty high. HLA-94 protocol has given room for survival for more than 54% of HLA-affected people to live up to 6 years. 2 months is the lifespan, meaning it's 2 months to death if untreated and it is inherited form. Let me explain. If the HLH diagnosed in this child is inherited form and is not treated on time, the child will live only for about 2 months. If there is CNS or central nervous system involvement, then we are dealing with worse prognosis at hand. That will give us the worst prognosis, CNS involvement. In children less than 6 months old, the chances of surviving will be remote. Hematopoietic stem cell transplantation will afford the affected people, in about 60% of them, to live for 5 years post-diagnosis. Relapse. Though you've done everything, made correct diagnosis, instituted the appropriate treatment, patient is getting well right now, that's not the end of the journey. It's pretty possible that there could be relapse. But we can reduce the relapse by reducing exposure to identify trigger or triggers. That will help greatly. With that, I've come to the end of this full presentation on hemophagocytic lympho histiocytosis. Thanks for listening. Remember to share this. Remember to subscribe to my channel. I appreciate it.